we have, patients who are surviving. We have, few patients who are still there without one eye, and this, what is that? Anil in eye department, no one prostho. He used to give those prosthetic eyes, and we have few patients like that.
After exenteration.
Yeah, exenteration. Yeah. So Vinay, the format will be, you will be speaking for 45 minutes. Okay. And 15 minutes you keep it open for question answers.
Yes, sir. I think only
and
half an hour.
Very simple. Medical students would be there, residents would be there, so that they get an interest in this topic and they are motivated to read more or discover more about what is happening about this therapy.
Sure, so I think I have a half an hour talk, 30 minutes, and
yeah, that's good. So
then
keep,
take
for interaction, no, yeah.
But sir's questions will be dangerous, Dr. William. But
no. They are all learning. They are all learning together. So yeah, keep it.
We were all scared of his questions during residency.
He has thought-provoking questions.
Yes.
Not dangerous. It makes you think. That's what learning, becomes more interesting. No.
We still remember when do you remove the drain when the purpose has been fulfilled. Yes. Till now I remember the answer.
Yeah. Eight o'clock we take the start, huh? 8 o'clock. Yeah, something.
So you have a surgical oncologist there, I heard, no? I think Deepak Jain had joined.
Yeah. Our own graduate, no?
Yeah, Deepak has joined, but then the cases which we are getting are stage 4.
So he's with you, Parvez. He's with you
with me right now.
Okay.
Yeah, he's with me. So what he is trying to try to identify cases of which are operable. So
it'll take some time.
It'll take some time, I guess. Definitely, he's going to be an asset for the institute.
But the good thing is you have a good medical oncologist and radiation oncology department. So I don't think it will be too much of a problem.
Yeah, absolutely.
And any new person like coming and starting a specialty as its own, will have the teething problems, number of cases, and he has to stay and build a rapport with the community and his reputation and all those things, and slowly then only patient starts coming up.
True, sir.
Vinay,
yes.
Don't mind asking me this. Which batch were you?
In 96.
Okay. And you are here till when? Were you here?
2014.
Okay. Thank you.
I'm Parvez's MS batchmate. Same batch, 2004. But Parvez is 1 year senior to me in MBBS.
Okay.
And he used to rag me.
Yeah, of course.
In one of your blogs, Vinay, you had shared that you were planning to do something for CAGB also, for HIPEC and PIPAC.
Yeah, we have done a couple of cases of both HIPEC and PIPAC for CAGB, but only if it's a peritoneal carcinomatosis. That means if the pattern of spread is along the peritoneum and not hematogenous or lymphatogenous. So if the lymph nodes positive or if it's intraparenchymal liver lesions, then we're not doing it. Of course, It's very experimental. Even the GB Pant guys have done a few cases, but since gallbladder cancer is an Indian disease, the Western literature can't support its use in gallbladder cancer. But I think it is showing promise even in this terrible disease. But if it should not be hematogenous spread, so we have to. There's a study happening in RNR also in Army Hospital in Delhi. They're trying to separate out the pattern of spread from the blood spread to the and peritoneal spread, and seeing if HIPEC or PIPAC can benefit.
Yeah.
So I've done a couple of cases of PIPAC in gallbladder cancer. So now of course it's not randomized, or it's not a study that we can compare to, but I think the results are pretty good, because the main issue with the blood actually doesn't reach the peritoneum well.
Yeah.
So systemic chemo really doesn't work wonders in this situation. So
yeah.
Especially platinum resistance.
Yeah, and one more thing. I mean, you said peritoneal carcinomatosis minus the lymph node and the hematogenous. So do you get us quite? I mean, there are patients who present like that. I mean, with this cancer, like kind of spreads real like fire, no? So I was
Yes,
just wondering.
so about 10 to 15% in India, we've seen that there'll be omental disease, peritoneal disease, and locally gallbladder with infiltration into the local infiltration into the liver. So those patients might be candidates for this. Of course, I can't say that with high level of evidence, but something that we're looking into as. So there are two societies in India. So peritoneal surface malignancy societies. So the data is being submitted into a common database with it's anonymous, so they won't really know which center it's coming from, and so hopefully there'll be some good publications about gallbladder cancer. So the ovarian cancer, pseudomyxoma, mesotheliomas, there are a lot of publications in India.
Yeah.
So there's a Dr. Somashekar Manipal he's got a large series of both HIPEC as well as PIPAC. So he's spearheading it in India. This thing.
Do you train in UK or US?
No, Germany. So PIPAC I trained in Germany. So you can't do PIPAC without a certification, because there's a lot of biohazard for the healthcare workers. So the certification, you have to go and get it trained. They had the first training center in Manipal this year. The beginning of this year. So there are a couple of more surgeons. Otherwise, I was the only one doing PIPAC in Delhi NCR. Sorry, in Gurgaon and neighboring side. But now 2 or 3 other surgeons have got certified. So HIPEC, a lot of people are doing. Almost every hospital is doing HIPEC now. Yeah.
So let's start. Good morning, everybody. Welcome to the Grand Rounds. Today we have Dr. Vinay Gaikwad, who is Director and Head of Surgical Oncology at Paras Hospital, Gurgaon. He's our own graduate, 1996 batch, and then he did his MS here, went on to Tata Memorial Hospital, Bombay, for his training in surgical oncology, GI surgical oncology. And then he came back and he was working with us till 2014. His better half also he picked up in CMC only. And she is junior to him by 4 batches.
Two batches.
2 batches, sorry, 2 batches. And both of them, they sing very well. And Vinay plays all the instruments you can name off. You name the instrument and he knows how to play. Very actively involved with the musicals. In spite of his all surgical commitments, and he used to find time for all those things, and he used to love it doing those things. And I'm sure he's missing all those things at his place in Gurgaon. And I request Dr. Vinay to please present his talk. Before you go for the talk, can I request Dr. William sir to welcome Grand Rounds?
Good morning, Dr. Vinay. Am I audible, Ashish?
Yes, we can hear you, sir.
Okay. Dr. Vinay, on behalf of CMC Ludhiana, I welcome you for today's Grand Rounds. And I'm sure today's talk will be good learning for all of us. As such, we are familiar with your work, which you are doing in the field of oncology. And I remember even from Delhi, you have come and assisted us in the resection of few tumors and pediatric surgery as well. And today's talk, following that, will be a beginning of new learning for all of us. And we will be in touch with you. Once again, thank you, Vinay, for joining us.
Thank you so much, sir. I would want to thank Dr. William Bhatti, our director of CMC, and Dr. Jairaj Pandian, the principal, Dr. Abhilasha, Dr. Ashish Varghese, Dr. Pervez, for inviting me for this talk. And I'm sure it will help both the faculty and the students to better understand this concept, because it's a relatively new concept that is becoming more prevalent, and I'm sure it will come into the mainstream curriculum of surgery and other subjects as well. And oncology, it's already a big subject. So without wasting any more time, I'll just jump into this topic called complete cytoreductive surgery, that is CRS, and HIPEC, which is hyperthermic intraperitoneal chemotherapy, and PIPAC, which is pressurized intraperitoneal chemotherapy for peritoneal surface malignancies. So we'll be understanding what peritoneal surface malignancies are. So what we have to understand before we start the topic is that when we were studying anatomy, or when we are studying anatomy now, we don't really think of the importance of the peritoneum. We just kind of brush through, this parietal peritoneum, visceral peritoneum, and we just brush it like I did. Although I was interested in anatomy, the peritoneum didn't seem to be something very important. So that's something we have to understand as an organ. And the second thing we have to understand in oncology is the pattern of spread. So I was discussing with Dr. Pervez before the session also that we have to understand there's a distinct pattern called peritoneal carcinomatosis. So because of this, there's a complete separate part subset of oncology called peritoneal surface malignancies. And it's really evolving during the last decade. Science is evolving, medicine is evolving, oncology is evolving at a great pace. So the basic concept is to remove all gross disease by surgery or cytoreductive surgery. And for the microscopic disease, or the disease we cannot see to the naked eye, that is when we use intraperitoneal chemotherapy. So it's a very surgeon-driven specialty, unlike most other diseases with advanced or stage 4 disease. It's usually medical oncology driven, and as Dr. Ashwin will vouch, so the surgeons play a secondary role in advanced cancers, and we are more active when it's coming to early stage disease. But this is an exception in which the surgeons take the lead even when it's very advanced. So there are a lot of improvements in the techniques and the management. So therefore, the results and both the short-term and long-term results have been much, much better, and it's gaining popularity. So although there are many techniques, we're going to discuss HIPEC and PIPAC, but there are certain techniques called early post-operative intraperitoneal chemotherapy, or EPIC, and even normothermic intraperitoneal chemotherapy long-term, in which the catheter is introduced into the peritoneal cavity and chemotherapy is given for over a long period of time. But we won't be discussing that because that's really not shown to have good results, and now that's more or less stopped across the world. Another thing we need to understand is India as a country is also a leader in this particular specialty, and there's a lot of evidence generated in India as well, and a lot of trials happening in our country. So that in India, the two major societies for this particular oncology specialty, that is the Society of Peritoneal Surface Oncology and the Peritoneal Surface Oncology Group International. So there are guidelines being released almost every year because it's developing so fast. And of course, virtual conferences now with the COVID situation. Otherwise, there was yearly annual conferences in which we could discuss and update ourselves about this part. Now coming to pseudomyxoma peritonei, which is usually an appendicular malignancy, and mesothelioma. So these two malignancies which comprise the peritoneal carcinomatosis, there's a very high level of evidence, or level 1 evidence, and it's a gold standard for the treatment of these two diseases. Ovarian cancer, colorectal cancer, gastric cancer, and even other rarer tumors like gallbladder cancer and so on. There's evolving evidence, level 2 evidence is available, especially for ovarian cancer. There was a recent study called the PRODIGE 7 trial for colorectal cancer, which caused some controversy, but things are settling again. So yes, the basic point is evidence is developing. I'm not going to go into too much detail because it's quite extensive, but yes, so there are many trials across the world that are generating evidence for HIPEC in colorectal, appendicular, gastric cancer. Now in gastric cancer, it has to be more selective. It's a more aggressive disease. Ovarian cancer is huge. The gynae oncology community is really has taken this up, and it's coming up in a big way, especially in the interval cytoreductive setting. And even in the upfront setting, now there's many studies that are awaited, like the OVHIPEC study in the Dutch study. So once that is available, it will be very often, you'll be seeing it happening more and more often. There are other rarer tumors, even we have done some for other tumors, but that is going to be more experimental and should be done in a clinical trial setting. Now, before we start any surgical planning, we calculate what's called a peritoneal carcinomatosis index. So I hope you can see in this diagram that there are 13 quadrants in the abdomen, the 9 quadrants as we know it, and there are 4 more quadrants, the upper lower jejunum and upper and lower ileum. So that comprises 13 quadrants. And then based on the volume of disease in each quadrant, it's classified into, we tabulate as 0 to 3. So if you calculate this, add all 13 quadrants and the size of disease, volume of disease, we come up with a PCI, or peritoneal carcinomatosis index. So that really helps us planning the surgery. This can be evaluated both by imaging. MRI is the preferred imaging, but CT scan is also good. Contrast CT is good to evaluate PCI. Many people use a diagnostic laparoscopy before starting the surgery, or even otherwise, to calculate the PCI. And we also calculate the PCI after we actually do the surgery to make sure that it's accurate and we have the complete picture. So what I'll do now is I'll quickly run through a short video how a CRS HIPEC is done, and then I'll show you some diagrams about how it's being done step by step. So this is a case that we did about 6 years back, one of my first cases, and it was a pseudomyxoma peritoneae, appendicular neoplasm. I hope the video is clear to
yeah,
to everybody.
it's very clear and a sharp image. It's working well without
Thank
any
you. So
interruption. Yeah.
thank you. So we are separating the peritoneal cavity before entering the we are mobilizing the peritoneum before entering the peritoneal cavity. If you look at this disease, it's such high volume. The PCI is very high, and normally one would think that there's no possible way we could remove all of this disease. But that's with modernization. So this is a small bowel mesentery. So there are numerous ways to dissect the tumor away from the mesentery, preserving the mesenteric vasculature. It can be done with sharp as well as blunt dissection with Kelly clamp, lysis, and so on. This is the disease on the stomach. So it's a short video just to give you an idea, and then we'll discuss it in detail. If it's too bulky, the disease, we think we can't really handle the disease, or serosal deposits are too high, we just resect that portion of the bowel with the disease and go on to perform the anastomosis later. The liver is another part that we look at. The glycinectomy is done, or the Gleason's capsule on the liver is removed, and a diaphragmatic stripping carefully done not to open up the diaphragm and cause a pneumothorax. So this is the anastomosis. It can be done either before the HIPEC is started or after the HIPEC is done. We do it before the HIPEC, but most surgeons prefer to do it after the HIPEC so that the chemotherapy can come in contact with the anastomotic site before it's anastomosed. So you can look at how clean it is after the surgery is done. And this patient is still doing well 6 years after the operation. He's in contact with me still. So after the cytoreductive surgery is done, we put in an inflow and outflow catheter with a temperature probe attached. You can see that gray tubing, which is a temperature probe to monitor the temperature. And we use a closed technique. So for 90 minutes, the chemotherapy circulated with this machine, which is the Belmont machine. This is we no longer use this machine. It's a very small portable machine that was cheaper for us initially, and now we've switched to another machine. So at about 43 degrees Celsius, the chemotherapy is circulated through the abdominal cavity, and after that is over, then we reopen the abdomen, check hemostasis, and then close up with the sheath and so on with drains. So the steps of this procedure have been demonstrated by Dr. Paul Sugarbaker in detail. He's the father of HIPEC as we know it in our generation. So uh, this is what I want to go through step by step. The peritoneum is being dissected away from the posterior rectus sheath and transverse muscle. So nowadays we use these retractors to get good exposure. I have another short videos which I'll show you in which we're using these, and the diaphragmatic stripping of the peritoneum, and then going to the lesser sac. This is the lesser sac between the inferior body of the liver and the lesser curvature of the stomach. If you know that all the portal structures are right over this, so it has to be done very delicately, not to injure the portal structures, which can be disastrous. And so the lesser curve is another challenging part, which maybe we can use a ball tip cautery or other dissecting techniques, which may be helpful to protect the vital structures. Also, since because of gravity, usually all the liquid components of the pseudomyxoma kind of settle down into the pelvis, and by and large, most patients we have to do a rectal excision or an anterior section, or many times we also have to do a hysterectomy with the BSO, and then the anastomosis is done as shown. So these are how the drains are placed in. We don't use the Tencoff anymore, but the 4 drains, the inflow and outflow catheter, and that's done. So I want to show you more recent video we have done of a HIPEC for pseudomyxoma, because that's the most easy to understand. So we're looking, this is an appendicular neoplasm. So it's usually a low grade tumor of the appendix. You can see how the appendix bursts, releasing the mucus, and that is freely floating within the peritoneal cavity, and it kind of latches onto the peritoneal surface. And this is the supracolic omentectomy that we're carrying out. We should try to do an en bloc resection as much as possible. So the peritoneum should be excised in toto as much as possible. Now we're moving to the lesser sac and trying to complete the omentectomy with the cautery. So we can use a variety of energy sources, the ligashore, harmonic, and so on. But the cautery is still the mainstay, and it's usually done at a very high setting of coagulation, say 50 or 60, and many times a ball tip. So this is the lesser curve of stomach again, and this is the periportal region or the lesser sac region that we are dissecting. So it's a very tedious process to do a good cytoreductive surgery, but it's worth it at the end. So again, moving to the diaphragm, doing the diaphragmatic stripping. This again, like I mentioned, many times we enter the pleural cavity and have to put an intercostal drain, which should be avoided whenever possible. The falciform ligament is mobilized up till its origin, up till the left portal vein, because that's where the disease sneakily hides away from sight, and we think we've done everything. So in this case, we've done a right hemicolectomy because the tumor was infiltrating the cecum. So we don't have to do what's called this complete mesocolic excision, which we do for adenocarcinomas, but a standard right hemicolectomy was sufficient in this patient. And then we went on to do the anastomosis after resecting the right colon. I think this was an extended right hemicolectomy. So it's handy to have staplers and the other gadgets we use routinely. But our anastomosis are still hands-on because that's where we have the most confidence. So after the cytoreduction, you can see again it's quite a clean peritoneal cavity. Everything has been cleaned out, and even the uterus and ovaries have been removed. And that's what the specimen looks like after the resection. And we use the smoke evacuator nowadays so that, there's a lot of smoke that's generated during this procedure. Then the catheters are placed, again, as mentioned before, and the abdomen is closed temporarily. So this is the new machine that we're using now. Called it's a company called RAND, which is really advanced machine, the best we have till date, and that really monitors the temperature well in each quadrant. And this chemotherapy is then circulated for 90 minutes. So in pseudomyxomas, we're using a combination of cisplatin and mitomycin C, which has shown in many studies to be the best chemotherapy regimen for intraperitoneal use in pseudomyxoma. But in ovarian cancers, we use slightly different, only cisplatin, and colorectal auxiliary platin is usually not used anymore, but we're using cisplatin and so on. So another technique can be the open technique. I've showed you the closed technique. The open technique or the coliseum technique is when the abdominal cavity is left open, and the chemotherapy is instilled, and the surgeon kind of keeps circulating the chemotherapy with his hand to ensure that it circulates throughout the peritoneal cavity. We use the closed technique. Now, understanding why do we use HIPEC? So understanding the pharmacokinetics and molecular pathway. So the heat increases the chemotherapeutic drug penetration to almost 6 millimeters. So like I mentioned before, we can't substitute a good surgery with HIPEC. We have to remove all gross disease, and then only the microscopic disease should be left behind for the HIPEC to handle. The heat itself causes anti-tumor effects and increases cytotoxicity of the drug. Platinum resistance, which is a big problem, also is circumvented with hyperthermia. And because of the plasma peritoneal barrier, there's less systemic toxicities, as you would expect with systemic chemotherapy, which is given IV or orally. The time and the currents also allow any small tumors left behind to be moved with the current and excised. So there's so many chemotherapy regimens that are used. It's still, again, evolving and being better understood. The most commonly used drugs are cisplatin, mitomycin C, and in the past oxaliplatin, but that's getting less and less in vogue. So that machine is the Belmont machine that we just showed. In between, we use this machine called the thermal solution machine, and now we've settled with this machine called the RAND machine. So it's fairly expensive. It costs about 1.5 to 2 lakhs in our center, over and above the normal cytoreduction. So I would say between 5 to 6 lakhs for the procedure. So this is our series of about 64 patients over 6 years. Not a very large number, but we're picking up numbers more and more, and getting better results with our patients. So now switching over to another procedure called PIPAC, which is pressurized intraperitoneal aerosol chemotherapy. So it's very important to understand the difference between what we just discussed, HIPEC, and now PIPAC. So it's easy to club these two as a common procedure, but it's very, very different, and we have to understand how it's different. So this is it's a relatively minor procedure, although it's done under general anesthesia. It's a new chemo delivery system. So laparoscopy is used to deliver chemotherapy intraperitoneally. So we place 2 laparoscopic trocars into the peritoneal cavity, and the chemotherapy is injected through a pressure injector, through a pen called a capno pen, which kind of converts the liquid chemotherapy into gaseous form or aerosolizes it. So just like how we have a deodorant spray. And this sprayed chemotherapy sediments across all the peritoneal surfaces in the peritoneal cavity, and that's how this procedure is done. So it's a palliative procedure. It's not a curative procedure. It's done only for palliation when systemic chemotherapy is no longer effective, and there's a very strict selection criteria for this. So I'll show you this a short video about PIPAC procedure. This is again requires certification because there's a lot of biohazard to the healthcare workers if it's not done well. So again, this diagram depicting the sense of the procedure. So we attain pneumoperitoneum with either the Veris needle or open technique as a standard laparoscopy procedure, and it has been done carefully because many times the patient has been operated in the past and a lot of adhesions, either because of the previous surgery or because of the tumor itself. So there's special trocars that need to be used, which have a balloon on the inside, which can be insufflated to ensure complete air tightness and there's no escape of gas into the operation theater complex. Biopsies can be taken from four quadrants to assess tumor grade histopathologically and assess response to this procedure. So that has to be done carefully to ensure there's no bleeding or any problems like that. So this is the capno pen that's used. It's a device that I mentioned that converts the chemo to the aerosolized form, and we have to keep the camera on in one port and the capno pen on in the other trocar, and the pressure injector is then connected to the capno pen, and we all leave the operation theater, including the anesthetist, because the chemotherapy is in a gaseous form and we have to avoid contact with it. And so you can see the chemotherapy being vaporized here in the peritoneal cavity. We are all standing outside the operation theater while the procedure is going on. So that's allowed to sediment for 30 minutes. And then we come in and evacuate the chemotherapy through, again, like I mentioned, this closed evacuation system. This is Professor Mark Raymond in Germany, who is the father of this procedure. So there are a lot of people who are to be credited for this procedure. So we're the early adapters, but they're the ones who innovate and have introduced the world to this procedure, which is benefiting many patients with advanced malignancies. Coming to the differences between HIPEC and PIPAC very basically. So HIPEC is a curative procedure with a curative intent. So we remove all disease with curative intent. PIPAC is a palliative procedure. So it's for when we think that the other modes of palliation are no longer effective and the patient is still fit for a general anesthesia procedure, we can think of PIPAC if they fit the criteria. PIPAC is a supramajor procedure, takes many hours to do, extreme skill required, whereas PIPAC is a limited risk procedure and is not too demanding in terms of skill when we look at it that way. The tumor is completely removed in HIPEC and there's absolutely no resection procedure in the PIPAC procedure, just the installation of chemotherapy. So HIPEC is a much older procedure and the use is much more widespread, whereas PIPAC is still developing and being better understood. So they're completely different skill sets required and different equipment. Although the concept is similar, that chemotherapy is introduced intraperitoneally. Coming to a few future directions, there's some studies evaluating intraperitoneal immunotherapy. That should be interesting. And e-PIPAC or electronic PIPAC is also a new procedure underway. So so it's important to collaborate with these leaders in the field. And you'll see our alumni, Dr. Sanjeev Dayal, who's in Basingstoke. That's one of the highest volume centers for HIPEC in the world. So he's leading from there. Then Dr. Avdish Saftlani in Tata, and a lot of French and German investigators. Also, it's useful to interact with them and understand how we can proceed better. So in conclusion, before we have questions, I want to summarize by saying that we are still understanding the roles of shares in HIPEC. There are many phase 3 trials underway, which will help us to understand exactly the indications and contraindications for this procedure. But it is a novel technique and details are still evolving. It definitely has a complementary role to play with cytoreductive surgery, the HIPEC, and is improving survival more and more with better techniques. And PIPAC is also a promising palliative option, especially for platinum-resistant, chemo-resistant abdominal cancers. But it requires dedication and teamwork like any specialty. And if the team is all synchronized and dedicated to this particular field, it can be taken forward. So there's no shortcut to this field. And I want to thank you all for your attention. And I will be happy to take any questions regarding this topic.
Thank you, Vinay, for this talk and use those videos and all those things. There are a few questions in the chat. Dr. Pamela Jara, she wants to know what dose of cisplatin have you used? Because the studies, they mention a range from 50 to 150 milligram per meter square.
Yes, so we have also experimented with a lot of doses, like she mentioned very rightly. There are so many studies with different doses. So in pseudomyxoma, since we instill both mitomycin C and cisplatin, the dose of cisplatin is reduced, but we calculated per body surface area. So our medical oncologists are on board with us, and they formulate the. I'll just go back to my video on HIPEC and show you that we have a chemo protocol here. I'll go just get to that part quickly. So a chemotherapy protocol is made for each patient based on the body surface area. So it's not a standard dose. We don't use a standard dose for every patient. It's based on many factors. So I think it's not opening. Okay, it should come now. I think you can still see my slide sharing, if I'm not mistaken.
Yeah, we can see the slide share. Yeah. And the video also is moving now.
Yeah. So I just want to show you the protocol we make. So even the systemic toxicities have to be managed intraoperatively. So just a second, it's coming there. Yeah, so it should be here soon. Yes, so this is it. So in this patient, we've used cisplatin at 60 milligrams per meter square. So 90 milligrams here in this patient. That is because this is a monotherapy on the single drug, but with mitomycin C, obviously we use a lesser dose of mitomycin C.
Yeah, Dr. Preeti Paul, she wants to ask, what is the role of HIPEC in pancreatic malignancies?
Yeah, thank you for the question. So there are actually no studies, I would say, on HIPEC with pancreatic malignancies, because I was discussing with Parvez also before this. We have to understand the pattern of spread. So HIPEC should be used only when there's a peritoneal carcinomatosis, or the pattern of spread of the disease is peritoneal and not hematogenous or lymphatic. So if they're positive lymph nodes, or if they're distant mets with intraparenchymal liver lesions or lung lesions or bone lesions, then actually HIPEC has absolutely no role, because it's only tackling peritoneal disease. Like in gallbladder cancer, there's a minority of patients with pancreatic cancer that have peritoneal disease only, but it's a very, very small quantity. I would say less than 5 to 10%. So it's very difficult to tag those patients and actually do a worthwhile study on that. So I have no personal experience with HIPEC in pancreatic cancer per se, but yes, in gallbladder cancer, we have done a couple of cases with gallbladder cancer with peritoneal carcinomatosis and not any distant met. So with omental disease, with peritoneal disease only, it can be worth pursuing. So mixing a Whipple procedure with a HIPEC procedure is something that I would not be too comfortable doing at the moment until we have some evidence.
Yeah, thank you, Vinay. One more question, Dr. Roma Isaac, she wants to know, any difference in the response with low grade, high grade pseudomyxoma?
Yes, so HIPEC is extremely useful in low grade appendicular neoplasms or even primary peritoneal disease. The reason it's a gold standard for pseudomyxoma, this HIPEC is a gold standard because systemic chemotherapy really does not act on low-grade tumors. So the low-grade tumors do extremely well after HIPEC, and disease-free survival has been reported to be more than 5 and even sometimes 10 years in some studies. But in high-grade neoplasms, the results are not so good because again the mitotic activity is higher, and many times we give adjuvant systemic chemotherapy for high-grade neoplasms. But in low-grade neoplasms, we just observe after the HIPEC. We don't initiate systemic chemotherapy in low-grade appendicular neoplasms, especially LAMNs.
Yeah. Dr. Ashwin Phillips, he wants to know the new NCCN, it now mentions about, giving interval cytoreductive surgery and, HIPEC. What is the role in ovarian cancer, upfront setting?
Yes. So the upfront setting or the interval. So he's absolutely right. So because of the Dutch study, there are randomized control trials now, characteristically stating, documenting the improved survival with Sears and HIPEC in the interval cytoreductive setting. That means after neoadjuvant chemotherapy. That's what it means. So if it's a stage 3 ovarian malignancy and neoadjuvant chemotherapy has been given, now it's becoming a standard of care to do CRS and HIPEC in ovarian cancer in that setting. But coming to the upfront setting, that means before any chemotherapy is initiated, if we are taking the patient up for surgery or cytoreductive surgery without chemotherapy, that evidence is still evolving, although there's a recent Chinese multicentric study, a randomized study actually, that shows improved survival. So that's a study I quote. So I do offer patients HIPEC in the upfront setting as well in ovarian cancers, stating that it's still not a high level of evidence and explaining that, but we are doing upfront cases. But in the interval cytoreductive setting and even in the recurrent setting, in the secondary cytoreductive setting, it's showing more promise. And that's why the NCCN guidelines have now included that in the interval cytoreductive setting, HIPEC.
Yeah. Dr. Asim Jindal, he wants to know what is the disadvantage of doing an anastomosis before HIPEC?
This disadvantage is that, as you've seen in the anastomotic in the video, that the edges, the margins of the anastomosis, once you complete the anastomosis, are no longer subject to contact with the chemotherapy drug while the HIPEC is going on. So that is why most surgeons perform the anastomosis after the HIPEC is completed, so that the staple line and the anastomotic margins are exposed to the drug if there's any microscopic disease on it. Personally, I do the anastomosis prior to the HIPEC because logistically it's much simpler that way, and I'm more comfortable to do it. The bowel edema might be there after the chemotherapy, and that might increase the risk of anastomotic dehiscence. But yes, so I think both techniques are acceptable, but by and large across the board, I think the anastomosis is done after the HIPEC more often.
Dr. Harish Ishwaraya from Australia, he's first of all complimenting me about the talk. It was a great talk, and then he wants to know that you mentioned HIPEC as a palliative procedure. So what exactly are you palliating or trying to improve? The symptom, the survival, the tumor burden, the quality of life, etc.
So HIPEC has been
PIPAC. Yeah.
Yep. So PIPAC is a palliative procedure. So I think we are trying to improve all the above endpoints that you mentioned: the quality of life as well as overall survival. We obviously can't improve the disease-free survival because there's disease already present. So the basic concept is why PIPAC is so effective is that especially in platinum-resistant ovarian cancer. So that's where the concept started in ovarian cancer, which is no longer chemo-resistant, chemosensitive. Because of direct contact of chemotherapy, what happens is why patients with ovarian cancer die is that the tumor deposits on the small bowel cause intestinal obstruction, and therefore the patient is no longer able to have adequate nutrition. And an obstruction in ovarian cancer in previously was called a terminal event. So many times we couldn't even make a stoma to palliate that system. So if we can debulk or we can shrink the disease with PIPAC, with intraperitoneal chemotherapy, that's been shown to really improve the quality of life, improve the increase in nutrition, and studies, even ongoing studies, are showing that the overall survival is increases, which is what we're really trying to do. Having said that, PIPAC has been shown to be so effective in some patients that after PIPAC, after 2 or 3 sittings of PIPAC, the patient actually underwent CRS and HIPEC in a curative setting. So, in fact, when I was training in Germany with Dr. Mark, he showed us a series of patients who have undergone HIPEC after PIPAC. So they were initially hopeless cases in people, which were chemo resistant, and nobody really thought they would live too long. But in his experience, he's shown a lot of patients who have undergone HIPEC after PIPAC. But in oncology, as Dr. Ashwin and Dr. Pamela and the others here in oncology will agree, that we have a saying that tumor biology is king. So, and so we are all the prince and princesses trying to do something, whatever we can. But ultimately, what rules the day is the tumor biology. So it's important to assess tumor biology. PIPAC is done at intervals of about 6 weeks. Usually 3 sittings of PIPAC is recommended. But that's also evolving in terms of how the logistics and how it should be done. So I hope that answers the question. Yeah.
Yeah. Dr. Kavita wants to know how many cycles of HIPEC can be given in recurrent malignant ascites, survival rates after HIPEC.
So HIPEC is, so I think we are clear about the concept difference between HIPEC and PIPAC. So HIPEC can be done again more than once. So we have done a few redo HIPECs, but by and large, it's a end-all procedure, and we should try to do it a single time. But yes, redo HIPECs are done. Refractory ascites is not a good indication for HIPEC per se, but yes, it has been done in some cases. So palliative HIPECs usually have not shown good results in studies as a palliative procedure. Especially, it's tempting to do it for ascites, assuming that the ascites will resolve with the intraperitoneal chemotherapy. But both in studies as well as in my personal experience, I don't think it's a good indication for doing HIPEC, just ascites. Unless we can do complete cytoreductive surgery, remove all gross disease, just play simple ascites is going to be a nuisance, and really, especially if the patient has undergone repeated ascitic tappings and there's some amount of infective ascites, HIPEC will kind of aggravate that, because it's chemotherapy. It will, create a big problem. You'll aggravate the problem. So I would not recommend that for ascites alone.
Yeah. I can see 2 people raising hands. Parvez was there, I saw, and then Dr. Pamela. So Parvez followed by Dr. Pamela. If you want to ask directly Vinay the question, you can. Yeah.
Hey Vinay, thanks. This is a lovely presentation. I just wanted to ask for the medical students, what will your surgical endpoints be intraoperatively when you've done your peritoneectomy? I mean, you showed us the PCI, and what the students need to know is that, look, this is the point where you say, now I have removed the gross disease, as you said. How do you have a score on that, or do you have a visual score? Yeah.
Right. So thanks for the question. I think I missed that. So that's an important point that you've raised. So we scored, but like in oncology, we have the R scoring, the R0, R1, R2. So R0 means complete microscopic disease also has been taken with margin free. R1 is with gross disease has been removed, but microscopic disease is still there. And R2 is when we have left gross disease behind. Similarly, when we're talking about peritoneal surface malignancy, we have what's called CC0, complete cytoreductive score, CC0, CC1, and CC2, and so on. So we have to aim for CC0, that is complete cytoreductive cytoreduction 0. That means there's absolutely 0 disease left behind, no gross visible disease. CC1 is if there's, less than 2 millimeters of disease left behind, and if there's more than 2 centimeters of disease left behind, if you club it all together, it's CC2, which is really not the way to go. So we have to attempt to get CC0 in every case of HIPEC, and that is when we see positive results. If there's gross disease left behind, it won't be. It might not be worthwhile even doing the HIPEC at all.
Yeah. And my second question is, we both trained together and we looked at stage 4 disease as something very abysmal. So for you going into the stage 4 disease and, fighting, doing all this peritoneal carcinomatosis, how easy was it for you to get into this concept and,
it was a very difficult. Thanks, Parvez. Yeah, so we had some good times together in our training. So we're MS batchmates. So it was really fun working with Parvez. So yeah, it was a challenging subject. So when I personally started this 6 years back, roughly 6 years back, almost more than 6 years, it was already happening in India, but it was a very nascent phase. So in Gurgaon, where I work, it was the first case being done in the entire region, including Medanta and Artemis. Nobody had done it. So I was very afraid, because if something went wrong, there would be a lot of people, that criticize it, like in any new technique, as you know, surgical technique especially. So they're very, like when laparoscopy started, if you remember, people were criticizing it, and now it's a standard of care across the world. Similarly, I'm sure that this peritoneal surface malignancy will be, and is becoming, if not already is, the standard of care for peritoneal surface malignancy. HIPEC is the standard of care. But yes, it is very challenging. The training was not very freely available at that time, so it was tough to understand the concepts and how to do it safely. The morbidity was higher at that point, but now over the years we're nearing 0% mortality and very minimal morbidity with these procedures. And we have a good team. So the critical care specialists, the anesthetists, the surgical team, medical oncology, we all have to work cohesively, and teamwork is something that really can't be substituted. None of these things are one-man shows, and that's how we can get the best results possible.
Thank you, Vinay. Thank you for great hearing you. Yeah.
Thank you.
Dr. Vinay, it was an excellent presentation, and
you,
we've been reading about it, but it was so nice that you could show us the videos. Our residents are also there. It's like seeing a live case being done. I have some very simple questions just for my knowledge. Just curious to know, when you showed about the peritoneal carcinomatosis index, so there were 13 quadrants. Why is it that other than the normal quadrants, there are 4 of them, which is upper jejunum, lower jejunum, upper ileum, and lower ileum? Why is it separately given? Is there any significance?
I'm surprised that you asked that question. From a non-surgeon, hearing that question is very, it's pleasantly surprising because yes. So initially, when we all wondered that, but when you actually do the procedure, you understand. So there are a lot of Achilles heels or the weakest points of this procedure. So the root of the mesentery is somewhere we really don't want to be messing around. So we cannot resect. Suppose the proximal jejunum or the DJ flexure ligament of Treats, if the tumor collects over there, I would say if you ask me, the single most important reason I would not go on and do a HIPEC is if these 4 quadrants that you mentioned have high volume disease. Because that would mean removing the proximal small bowel, which is a disaster actually, because if it leaks there, if the anesthetic leak happens there, we can't even make a stoma, and that's kind of a death sentence for the patient, because the high volume bilious enteric content will be coming out, no way to control it. Peritonitis in the background of intraperitoneal chemotherapy is a recipe for disaster. So that is why Dr. Sugarbaker coined these 4 terms, these 4 sites, because they could be at any quadrant. So the small bowel, as you know, is a freely moving intraperitoneal structure. So these structures don't really conform to the other 9 quadrants in the abdomen. So the proximal ileum could be in the left upper quadrant, it could be the right lower quadrant, it could be anywhere. So they're mobile structures, and that is why, for the sake of documenting PCI, these four separate entities have been formed, and they're really game changers. So, for example, if I were to think of, let's say, gastric cancer, I would not do a HIPEC if the PCI is above 11 or 12. In pseudomyxomas, obviously, the high PCIs, we still go ahead because it's low-grade tumor. But in more aggressive cancers, we would not do, especially, in fact, even if the PCI is low, but if these particular quadrants are high PCI on diagnostic laparoscopy, I would still back out from a HIPEC because it's really precarious to resect those particular portions in our surgical sphere.
My second query is why is this PIPAC is aerosol based, no? So because it's gaseous, this thing, penetration is more, and the surfaces which we cannot reach otherwise, they are also reached. So why are we calling that as a palliative procedure when it reaches the difficult sites which otherwise?
So yeah, another good question. So palliation means that we can never hope for a possibility of cure because we're actually not resecting any tumor. Although the tumor penetration is there, like you mentioned very rightly, it can actually even penetrate otherwise quadrant out areas. Like suppose there's adhesions of the bowel. It has been studies, animal studies, and even some human studies have shown that it can penetrate even quadrant out areas maybe in the pelvis or in the supradiaphragmatic the subphrenic regions. So the reason it's called palliative is that we especially as surgeons believe that there's no cure without surgery. So without removing the tumor mechanically or physically, there's no possible way that the patient will be cured of the malignancy. But yes, as Dr. Harish was asking, we can improve the quality of life. We can improve the overall survival with PIPAC. So because of that reason, it's called a palliative procedure. But if it can be downstaged or depulped with PIPAC and then move on to a CRS and HIPEC, then the whole paradigm changes from palliative to a curative intent. So obviously we cannot always cure, but our intention is curative when we're doing a HIPEC, and our intention itself is palliative when you're doing a PIPAC procedure for that reason.
This last query, is there any, you spoke about the PCI and you also CC1, CC2 and all. So is there any relationship between these? Like, do you decide to go on based on the peritoneal carcinomatous index, or what is it? And we also talk about optimal cytoreduction, that is less than 5 mm of tumor left, that will come to the lowest PCI stage, right? Index. So
Right.
is it, yeah.
Right. Yeah. So again, a good question. So optimal cytoreduction and debulking as terminologies have been looked down upon now. We frown upon it because optimal is like how much I feel I should do. So it's up to the surgeon. It's very subjective, and it should not be. It's discouraged now. So that's why this concept of CC0 and so on. So coming to very important in assessing PCI is the imaging. So it's very good to have a good radiologist who can really assess PCI radiologically, and the investigation of choice we follow is a MRI. Although reading MRI for surgeons is a little difficult, so we still prefer CT imaging for assessing PCI. But even more importantly, what we do and most surgeons do is diagnostic laparoscopy before carrying on with the CRS and HIPEC, especially in these borderline cases like you're asking. Now, if you ask me if a pseudomyxoma has a PCI of 23 or 24, I would still go ahead with a HIPEC. But if a higher grade malignancy like a stomach cancer, gastric cancer, a PCI of 12 also would be above that would be a no-no for me. Signating cell stomach cancer, I would not even do a HIPEC. They're very aggressive tumors. Colorectal cancer, as you know, the PRODEED 7 trial, ASCO was a big hue and cry. They randomized 2 arms, CRS with or without HIPEC in colorectal cancer with peritoneal carcinomatosis. It was a multicentric French trial, and it showed no survival advantage with HIPEC when added to CRS in the setting. But the fact is, how many of us would do a CRS with peritoneal carcinomatosis in colorectal cancer? We would just be doing systemic chemotherapy. So that actually encourages to go ahead with surgery, even with advanced colorectal cancers. And now this, like I mentioned, there are many studies coming up which are supporting HIPEC even in the colorectal cancer setting. So I don't think any surgeon has stopped doing HIPEC for colorectal cancer even after these studies, because we are seeing the results in front of us. Until it's documented better in studies, we still have to be a little careful and more highly selective in our patient selection.
Thank you so much. Thank you.
Thank you for your question.
One more question from Asim Jindal. You always do a diversion in case when anastomosis is lower down the ball.
Yes, so that's a very good question. Who, Dr. Asim, is he a surgeon? I don't know.
Asim Jindal, can you introduce who are? I mean, I don't know. Asim Jindal, from which department are you? Hello, Asim Jindal.
I think Dr. William, but he's raising his hand.
Yeah.
No. You ask first. You ask the question.
Yeah,
I know he's a surgeon only.
Okay, good. So that's nice. Nice to hear questions from surgeons who are interested. So as you know, in suppose even if you leave out the HIPEC part, when we're doing a low anterior resection, if you're going below the peritoneal reflection and doing a rectal excision, many of us would make a covering stoma prophylactically and not wait for not take a chance for anastomotic leakage. But having said that, with the improvements in techniques, and there's a Sugar-Becker technique, so we do stapler anastomosis with the circular stapler of the rectum, and then take buttressing, reinforcing sutures, mechanical sutures along that. And so if there's a single anastomosis and we're pretty happy with it, nowadays we avoid making a diversion stoma. But if there's more than one anastomosis, I would always make a covering stoma proximal to the distalmost anastomosis. Some people would take a risk, but I think the initial bravado we had of taking risks as surgeons, as we become more mature, we have played safe. So across the board, I would say if it's a high risk anastomosis, if you think there's a compromise with the vascularity, or if it's low down in the pelvis and the rectum, I would make a covering stoma. But if it's a little higher up, and if there's a single anastomosis, I think there's times we can avoid making a stoma. And the last many cases, I have not made a covering stoma if it's just a single rectal anastomosis. But if it's more than one, yes, by all means, I would go, because we have seen a couple of cases who have leaked after anastomosis, and it's disaster because the inflammatory response of the HIPEC, the chemotherapy is there in the peritoneum. The peritonitis really doesn't settle as it does settle even with a minor leak. So it's really a disaster and can be life-threatening if it leaks after a HIPEC.
Asim is a fellow in GI surgery. Asim Jindal.
Okay, right.
Dr. William, please ask.
Yeah, Dr. Vinay, excellent thought-provoking presentation. And you did good job by keeping your presentation short and giving more time for interaction. That was good move.
Thank you, sir.
I just want to ask simple question. As you have made statement, surgeons always think without surgery, cancer cannot be cured. And same thing you did in the first surgery, which in your video, patient is still following you after 6 years. So on what basis we can say HIPEC is responsible for long-term survival? I would say it is Vinay's surgery, good reductive surgery you did, and following that patient is surviving, not HIPEC. That is one. Second is any experience with pediatric age group?
So thank you for the compliments. I would say that surgeon is the single most important factor for long-term survival in this particular procedure. But unfortunately, surgery by itself is not very glamorous. Now, if you include this huge machine and it's a novel concept, it's attracting interests across the board. I mean, Dr. Pamela is also showing interest. If I say we do excellent surgery, they'd say, okay, what's new about that? There are many surgeons doing good surgery. So I think the HIPEC is game changing, no doubt about it. But I think, like you said, we cannot substitute good surgery with HIPEC. So if you're leaving gross disease behind, we can't expect HIPEC to cover that up. So the reason for these long-term survivals is that we do painstaking cytoreductive surgeries, and the HIPEC and the permanent, the dosage of the drug combination, the time duration of HIPEC, the machine used. These are very, very minor components, I would think, in the overall outlook. Coming to the pediatric age group, I'm absolutely not aware of any studies. I don't know which malignancies would be appendicular neoplasms, maybe yes. So there would be a pediatric age group, but maybe in the adolescent age group that would follow the similar principles. But I personally have no experience with pediatrics. We leave pediatric surgery up to the experts.
Thank you.
Yeah.
Thanks. Okay.
Anybody, any more questions? We have 2 minutes more. Vinay, like sir said, you kept the talk for 30 minutes and the remaining time for interaction. Otherwise, most of the time the take-home message becomes blurred. All the doubts and all those things.
No, I'm so happy that I got questions, because it's surprising that everybody already knows quite a bit about how things are happening, and I'm sure that CMC will start their HIPEC and peritoneal surface oncology program soon. They should. I think Dr. Deepak Jain has also joined.
Yes.
They're from Tata Calcutta. So Dr. Robin and all spoke highly of him when he was training there. So I'm sure he'll do something great in the near future. And if he requires any help from my side, I'll be happy to contribute.
And what about our residents or fellows who want to come and visit your place?
Yeah, sure. I mean, I had a couple of people coming. Yeah. Dr. Anish Varghese had come. He's working somewhere around here. Dr. Anish, I don't know if you remember him in.
Of course.
So he had come in. He had visited us, and a couple of other surgeons also. Vijay Bhaskar from Hapur was interested in coming, and so if anybody wants to come in, we can line up a few cases in a week, and it'll be useful to come and see. So the conference is also happening. Yesterday evening there was a conference from Netherlands, webinars, certification courses. A lot of things are happening because of COVID. Obviously, physical programs have been hampered majorly, but webinars are still ongoing. Practically, if you want to see how it's done and interact, you're more than welcome to step in at any time. It's not very far away. It's just 4 hours Shatabdi trip here. So more than welcome to anybody.
Thank you, Vinay, for that excellent presentation and making it very, very interactive and answering all the questions. And we hope to see you sometime soon in CMC Ludhiana once the COVID thing is over.
Thank you all so much. Thank you all so much. It was a pleasure seeing all of you again and interacting.
Thank you.
Have a great weekend, everybody. Next week, we would be having grand round presentation from the Department of Radiation Oncology. And Dr. Preeti Negi would be the speaker. She would be talking about the journey of radiation oncology towards precision. So, we look forward to having you again next week. Have a great weekend. Thank you. Thank you.
Thank you.